Good morning, everybody. It's another episode of Coffee with Clinicians. And this morning I have the lovely Dr. Amanda Killeen with us. Welcome, Dr. Killeen, and happy to have you on.
Thank you so much. I'm not a coffee drinker, and I don't do well with caffeine. So I got my water here with us.
So tell us a little bit about your background.
So I am a podiatrist. I did a 3-year residency at a VA, and then I came to UT Southwestern in Dallas to do a clinical fellowship in Diabetic Limb Salvage, which I completed this summer. And then I stayed on for an additional year to do research. That's where I am now.
That's awesome. And you are doing research with the great Dr. Lavery. So how is that being the girl in the bunch over there?
It's been great. So in residency, I had done a bunch of projects. I had always been a little bit overwhelmed or intimidated by research, especially in school. And then in residency, fell into a project and found out that, hey, I really like this. So to come to a place where I have nothing but support, we're drowning in data, we have so many patients, and we have people who are motivated, is the perfect place to learn.
That's awesome. So you did a recent pilot study on the effects of CDO therapy. For those who don't know, that's continuous diffusion of oxygen, on cytokines and perfusion, bacterial load, and healing with respect to DFUs. Tell us a little bit about that study.
So yeah, it is a pilot study, which means that it is small. It's basically, we had an idea and said, what do we think? So we do a small study first to see what we find, and then later that grows into future research. So this was 23 patients, all with chronic non-healing diabetic foot ulcers. We took tissue biopsies, sent them to the lab, looked for a bunch of different growth factors and cytokines. We measured skin perfusion pressure, we measured hyperspectral imaging, and it was only a 3-week study. So each person essentially was their own control. And so we didn't follow enough for people to achieve full healing, but we're using a surrogate marker of that 50% wound area reduction. So we did a bunch of statistics looking at the group in total, and then separating out the people that were on track to heal versus the people that weren't, to see really was there a difference between those cytokines and growth factors.
Now that's fascinating to me because I have a background in open abdomen management. So I worked with a very well-known colorectal surgeon and learned a ton. So in my world, in my background, cytokines are not a great thing. We think of them in the abdomen as a cytokine storm, and our patients probably going septic. So what role do those cytokines have in the wound healing cycle?
So cytokines and cytokine storm are two separate beasts. So cytokines themselves are just a group of molecules that are proteins. Essentially, they just signal other cells. And growth factors are a type of cytokine. The way that the words have kind of changed and the names of these groups have changed over several years and decades, but basically cytokines are just signaling molecules. They can tell cells continue growing, do this or that, die, everything in between. Where growth factors are the subset of the ones that are just growing. So cytokines, if we're measuring them, we're kind of seeing, is there signaling going on? And then if we look specifically at growth factors, we can kind of extrapolate to say, okay, is there growth going on?
So it's kind of like a marker, if you will, to tell us if there's progression.
Exactly. And when you're talking about cytokine storm, it is a storm, right? Things are going nuts. It's way too much, and there's all kinds of immune things going on. In the normal wound healing process, the inflammation stays is something that's normal. We expect that. Whether the wound gets stuck there and stays as a chronic wound or continues on to healing is a different story. So when we're looking specifically at wounds that are already stuck in the inflammation phase, we can say, okay, is it because the signaling is just not happening appropriately, or is it because the hosts themselves is not really putting up the right response? So a thing that you were bringing up was that, how do we really do that? So there's nothing that's bedside. There's not a good way to know that. And how we define chronic wound is normally, is it 30 days or older? Is it 6 weeks or older? Have we tried everything that we know and it didn't get better? We'll just call it chronic. Because there's no thing that's a point of care that we can say, it's chronic because all of these inflammatory markers are stuck.
Yeah, so
You have
that's
to
what I
take
was going to ask
biopsies.
you, is if there was a diagnostic test that could really tell us at that micro level, but it sounds like there's nothing out there.
Not bedside. So in this case, we did microbiopsies and sent them to the lab. So unfortunately, it's not something as easy as just getting some blood, spinning it down, point of care, like we do for other things in the clinic. And as clinicians, we mostly focus on things that we can see, things
Right.
that we can measure, things that we can touch, feel, smell, etc. But this, unfortunately, we're not there yet.
So is it common to see an increase of growth factors for previously non-healing wounds?
In our pilot study, we did see that. Two in particular were significantly different when we broke it down by the people who were healing and the people that weren't. So one of those was IL-6, interleukin 6 and interleukin 8. These are pretty common ones that get measured within the wound care world. And interleukin basically means between white cells. So we know there's communication that's happening, and in these people, these are the ones that the wounds were contracting. So yes, and we know that when people are using other products, you can get growth factors that are topical, growth factors that are in different products like biologics, particulates, injections, membranes, you name it. So it's something that even though we may not be specifically familiar with, we're still very comfortable hearing on a macro scale.
So you have fallen, after our previous conversation, I've realized that you've fallen in love with research. What would be your Utopia research project?
I've been thinking about this more. There are so many. So I think there's a big disconnect right now between what's happening on the macro scale and what is happening micro. Because especially for diabetic foot infections, there's a huge difference between the amount of bacteria and how the host is responding to bacteria when it comes to infections, which plays a huge role in outcomes as far as wounds in general, healing, things like amputations, reinfection, osteomyelitis. So if we can better understand how a patient with diabetes is responding to microbiome, to different bacteria, to different antibiotics, then we can understand better and hopefully get better outcomes in the future. There's a lot of great kind of bench work that's come out, but we're still not at a place where we can easily say, hey, we can just snap a picture or do some kind of a bedside test to see this, but at least we're getting there.
That would be awesome, especially here in South Texas, where we see a lot of, diabetes as a result of diet from culture, and probably 80 to 80, maybe even 90% of the people that I see at least have diabetes, if not a diabetic ulcer.
Yeah, I agree. And it's only getting worse, unfortunately. And especially here, I'm kind of in North Texas, you're on the South side, but we see all kinds of patients who come from other places. We don't know what their education has been on the disease process. So we do a lot of educating people. And by the time that we see them in the hospital, a lot of times things are pretty bad. So we're in salvage mode, trying to say, hey, this is what we're dealing with. This is the best we can do. But going forward, to avoid this, because as we know, re-ulceration rate is so high, re-amputation rate, and these patients are patients for life.
Yeah. And so with respect to your study, you guys used CDO therapy and it did show, some markers were occurring within those patients to show the progression of those wounds. Give me your distinction between oxygenation and perfusion, because this gets confused, I think, a lot, even with some clinical folks. And I think it's definitely, there is a difference.
There is a difference. So it comes back to definitions again. So when we're talking about perfusion, clinical side, we tend to use oxygenation and perfusion just interchangeably. It's not necessarily the case, but I view oxygenation more like a paper map where we're seeing where things are. So when you open up a paper map, you're looking at roads, you can see rivers, canals, mountains, you have all the topography, you have every single thing, every road that you could possibly take is there. So you know where you can go. But the difference is when you look at perfusion, you switch to Google Maps and you're seeing where exactly are the cars within these roads. Because sometimes it makes a huge difference. Sometimes it doesn't. If you're on a country road, you can guess how long it's going to take you based on how far it is. But
you're in Dallas traffic.
In Dallas, it's very different. So if you leave at 6 a.m. versus 6 p.m., it's going to be different. But if you're looking to see what exactly are those oxygen molecules doing, it could be that they're bound to hemoglobin and they're just not getting transferred on a tissue level. It could be that the blood flow is not good in the first place and the roads are washed out. So there is a difference, even though it is kind of minute. It's still understanding that perfusion is looking at where is the oxygen going and is it reaching its target.
That is awesome. I love that description because it paints like the perfect picture of understanding. You're absolutely right. You can put oxygen anywhere and you can see the available pathways that it can go in some type of imaging, but that doesn't mean it's going to go there.
Right, not necessarily.
Yeah.
And especially because pretty much all I do is diabetic foot. So we already know that some of the complications with diabetic foot is that there's all sorts of renal complications, and both of those create just really, really diseased vasculature, especially microvascular. So once you get past the ankle, all the vessels are small. So if you get an ankle brachial index, you can say, all right, at the ankle, we think we have this and this amount of blood flow. But when you get to the midfoot where you get to the toes, it's not the same story.
Yeah. Well, it has been a pleasure speaking with you this morning. I appreciate you taking the time to join us and with Coffee with Clinicians with your water. I'll switch to that later today with my Topo Chico.
There you go. We're in Texas.
That's right. That's right. So thank you guys for tuning in. I hope you learned something. I definitely did. And Amanda, we would love to bring you back sometime.
Hey, I'm always game. Thank you so much.
Thank you, Dr. Killeen.